So here we are with chapter 16, talking about public health law and how it applies in emergency situations. So when we talk about emergency preparedness, we have to remember that the law is not separate from public health. In fact, it's one of our primary response tools. During emergencies, public health agencies often rely on legal and regulatory authorities alongside surveillance, communication, and response operations to protect lives and try to maintain healthy conditions. Different types of emergencies, whether they're infectious disease outbreaks, maybe wildfires or environmental hazards, they all require different legal tools from emergency declarations to quarantine orders and remediation authority. Legal authorizations make interventions possible. Reporting requirements, mask mandates during COVID-19, for example, testing authority, property reentry decisions after wildfires. All of these are grounded in statutes, regulations, and judicial decisions. These legal frameworks enable screening, treatment, isolation, even the funding of different activities and coordinated response all across all levels of government. At its core, public health law is about two things. Number one, the state's power and duty to protect public health, and secondly, the limits on that power. Emergency response always operates in that balance, advancing the common good while we respect individual rights like liberty, privacy, and property as best as possible. Understanding that tension is central to modern preparedness. So, thinking about public health authority in the United States, we all have to begin with the U.S. Constitution. The Constitution defines what powers belong to the federal government, but just as importantly, it reserves broad sovereign powers to states, territories, and tribes. And this is the foundation of federalism. It also separates authority across legislative, executive, and judicial branches, which means emergency powers are always shaped by checks and balances. At the state level, each state and territory has its own constitution that provides the primary legal authority for public health within those boundaries. States can then delegate their authority to local governments. States with strong home rule provisions, local jurisdictions may have substantial independent public health powers. So when we discuss emergency preparedness, we're really operating within a layered constitutional framework. Federal authority, state police powers, and local implementation. All of these are interacting basically in real time during crises. Now, when we talk about federal authority during emergencies, it's crucial that we remember that federal government only has powers specifically enumerated in the Constitution. Some of those are operational, like coining money or establishing post offices, but the ones that really matter for preparedness are the broader powers to tax, spend, and regulate interstate commerce. Those authorities allow the federal government to regulate clean air and water, control disease spread across borders, and provide funding to states for emergency preparedness. At the same time, federal preemption means that when federal law conflicts with state law, federal law wins. This can occur through legislation, executive action, or court decisions. And just as the federal government can preempt states, states can preempt local governments. But under the 10th Amendment, powers not granted to the federal government are reserved to the states. This authority, or this includes the state's police power, their inherent authority to protect health, safety, and welfare. That police power is the foundation of most public health emergency actions, including quarantine, isolation, and other measures that may limit individual behavior for the public good. So, preparedness in the US operates with this constant balance between enumerated federal authority and broad state police powers. Now, these state police powers are the backbone of most public health authority in the US. These powers allow states to require school vaccinations, mandate food safety practices, restrict smoking in public, and even extend protections into multi unit housing. In other words, states have broad authority to regulate behavior in order to protect health and safety. States exercise these powers through laws, regulations, and executive orders. But while these powers are extensive, they're not unlimited. Every public health action must operate within constitutional boundaries, which means that balancing individual rights with community protection. Closely related is the doctrine of pens patriae. This idea that the state acts as parent of the nation. This authority allows states to intervene on behalf of vulnerable individuals, such as children or incapacitated adults, or even to litigate to protect the broader public welfare. We've seen this in actions taken against the opioid manufacturers, where states use this doctrine to address large scale public harms. Together, police power and pens patriae, these authorities illustrate how states operationalize public health protection during emergencies and beyond. Constitutional separation of powers is foundational to how public health operates in the US. The structure of checks and balances prevents any single branch of government from concentrating too much authority, even during emergencies. Legislatures create the laws that form the backbone of the public health framework. Courts interpret those laws and establish legal precedents that define the limits of public health authority. And the executive branch implements and enforces those laws in day to day public health practice, as well as emergency response situations. At the state level, constitutions mirror this separation of powers across state agencies. What's important for preparedness is that no single branch operates in isolation. Effective emergency response requires coordination across legislative authority, executive implementation, and judicial oversight, as well as across federal, state, and local levels. Preparedness, therefore, is not just operational, it's deeply embedded in constitutional structure and intergovernmental collaboration. So, when we talk about public health authority, we also have to understand that the constitutional protections that shape and limit it. The first 10 amendments, the Bill of Rights, establish fundamental individual freedoms in relation to the federal government. With the 14th Amendment, those protections are applied to the states as well. These rights include freedoms like religion, speech, and assembly, protection against unreasonable searches and seizures, and protections related to life, liberty, and property. The Fifth and 14th Amendments require due process, meaning that government actions must follow fair procedures and have adequate justification. The 14th Amendment also guards against arbitrary or discriminatory government action. Many legal challenges to public health interventions are grounded in these constitutional rights. So, in emergency preparedness, every intervention, whether quarantine, vaccine mandate, or business restriction, those all must operate within this constitutional framework. Preparedness is not just about authority, it's also about exercising that authority in a way that withstands constitutional scrutiny. When public health interventions affect individual liberties, courts have to evaluate whether the government action is justified or not. At a minimum, courts often require a rational relationship between the intervention and the public health goal. If fundamental rights are implicated, such as religious freedom, courts may apply heightened scrutiny and require a compelling public interest. Increasingly, courts also look at whether the government used the least restrictive means necessary. Fairness and proportionality matter. We saw this tension during COVID-19 quite a bit. Los Angeles County's temporary ban on outdoor dining was challenged, and initially a trial court found the order lacked sufficient epidemiologic support. An appellate court later upheld the order, demonstrating the deference courts often give to public health during emergencies. However, restrictions on religious services were struck down by the U.S. Supreme Court under higher scrutiny standards. The takeaway is that emergency preparedness is not just about acting quickly, it is also about building decisions on clear evidence, proportionality, and constitutional grounding so that they withstand judicial review. Jacobson versus Massachusetts is one of the most foundational public health law cases in U.S. history. During recurring smallpox outbreaks, Massachusetts had required adults to be vaccinated or pay a small fine unless they qualified for a medical exemption. The Reverend Henning Jacobson refused vaccination and challenged the law on constitutional grounds, ultimately appealing to the U.S. Supreme Court. The court upheld the law, affirming that states have the authority under their police powers to enact reasonable public health measures to protect the community. The court articulated standards that still guide emergency response today. Public health actions must be based on necessity. They can't go beyond what is reasonably required for public safety. There must be a real and substantial relationship between the intervention and the health objective. Measures must be proportionate, meaning that the burdens imposed cannot be excessive relative to their benefits, and public health actions cannot knowingly impose health risks on individuals. The Jacobson decision remains the constitutional foundation for vaccination mandates and many other emergency interventions. When we think about public health interventions during emergencies, it's important that we remember that officials are not improvising. They are drawing from a defined set of legal tools. These tools include actions that affect individuals like testing, screening, vaccination, quarantine, and isolation orders, as well as broader actions that affect businesses and communities, such as closures, evacuations, and environmental abatements. Quarantine and isolation are often confused, but they are legally and practically distinct. Quarantine separates people who have been exposed but are not yet sick. while isolation separates those who are known to be ill and contagious. Both are designed to interrupt transmission during critical windows of risk. These authorities are grounded in statutes that often apply across an entire jurisdiction rather than targeting specific individuals. Regulations provide more detailed guidance, and public health orders allow officials to respond quickly to urgent threats. Noncompliance can carry civil or even criminal penalties. Importantly, even with a formal emergency declaration, local health officers, such as those in California, they retain broad authority to act to prevent communicable disease outbreaks. However, these decisions must always be guided not just by law, but by science, ethics, and principles of equity. Public health emergencies operate within broader U.S. constitutional framework, such as federalism, separation of powers, and protection of individual rights. But there are also specific laws that activate during public health emergencies. Not every emergency looks the same. A localized chemical spill or foodborne outbreak might only require a state or local declaration, whereas a large scale event like COVID-19 triggered overlapping emergency declarations at federal, state, and local levels for a long time. The modern approach to managing these events is often called the all hazards framework. Instead of creating separate systems for every type of threat, governments rely on broad emergency or disaster declarations that can be adapted to many different scenarios. These are typically managed by emergency management agencies at the federal, state, tribal, and local levels. Over time, lawmakers have refined this framework to clearly define what constitutes a public health emergency. They authorize both public and private sector response actions, and they improve coordination across jurisdictions. The key takeaway is that emergency authority is not improvised. It is structured, legally grounded, and designed to scale up depending on the threat. When we shift from state police powers to federal emergency authority, the structure changes. Federal powers are more limited in scope under federalism, but when activated through emergency statutes, they are extensive, detailed, and supreme over conflicting state laws. Most federal emergency authority flows through three major statutes: the Stafford Act, the National Emergencies Act, and the Public Health Service Act. The Stafford Act declaration typically follows a governor's request and mobilizes FEMA and federal disaster assistance. Under the National Emergencies Act, the president can unlock a wide range of executive powers. Separately, the HHS secretary can declare a federal public health emergency, which lasts 90 days and can be renewed after that indefinitely. The declaration allows grants, contracts, emergency funding, regulatory waivers, and emergency use authorizations through FDA. During COVID-19, we saw this full framework in action. Emergency use authorizations enabled rapid vaccine distribution. Medicare and Medicaid requirements were temporarily waived, and sweeping legislation like PAPA, the PrEP Act, CARES Act, and the American Rescue Plan funded response efforts, expanded telehealth, protected medical volunteers, supported hospitals, and provided liability protections for medical countermeasures. One of the key takeaways here is that federal emergency law is not just about declarations, it's a layered system of authorities that mobilizes funding, regulatory flexibility, liability protections, as well as coordinating national action. After 9/11, states significantly modernized their emergency public health laws, largely influenced by the Model State Emergency Health Powers Act, or MASIPA. This model legislation created a structured framework that states could adopt to strengthen their ability to detect, prevent, and respond to bioterrorism and emerging infectious disease threats. Under MASIPA, a public health emergency is broadly defined as an actual or imminent threat posing a high probability of substantial deaths, disabilities, or future health harms from infectious or toxic agents. Once it's declared, it activates a coordinated set of powers. These powers include real-time testing, vaccination, quarantine and isolation, temporary closures, evacuations, control of essential supplies, as well as the use of private property with compensation, licensure, reciprocity for out-of-state providers, limited liability protections as well. Importantly, the Act also builds in constitutional safeguards, emphasizing due process, equal protection, and limits on abuse of authority. We saw widespread use of emergency authorities during COVID-19. However, even during declared national emergencies, states cannot waive constitutional requirements. Emergency powers are broad, but they are not unlimited. Actions that conflict with constitutional norms, such as interfering with interstate commerce, those remain legally vulnerable even in public health crisis. Emergency authority expands state capacity, but it still operates within constitutional boundaries. Now, this case begins in late 2019 when reports of a novel coronavirus emerged from Wuhan, China. Within months, COVID-19 spread globally, and by March 2020, we were facing a worldwide pandemic. What quickly became apparent was the differences in legal authorities across states, which led to very different public health strategies and responses. At the federal level, authority is powerful, but it's limited. The federal government can regulate interstate commerce and attach conditions to federal funding, but it cannot exceed its constitutionally enumerated powers or compel states to enforce federal law. Early on in the pandemic, national emergency powers were activated. On January 31st, 2020, HHS Secretary Um, the HHS Secretary declared a federal public health emergency, which unlocked emergency funding, regulatory waivers, and expanded telehealth. A PrEP Act declaration soon followed, providing liability protections for medical countermeasures. On March 13th, President Trump issued emergency declarations under the Stafford Act and the National Emergencies Act, which enabled FEMA support and broader regulatory flexibility. Shortly after that, the Defense Production Act was used to accelerate manufacturing of critical supplies like PPE and ventilators. The key takeaway was that layered federal emergency authorities allowed rapid mobilization of funding, expedited regulatory waivers, liability protections, as well as expanded industrial capacity, all within constitutional constraints. At the state level, public health authority is at its strongest. States hold primary responsibility for protecting health through their police and patriot powers. When a state declares a public health emergency, it unlocks authority to issue isolation and quarantine orders, impose curfews, close businesses, mandate testing and vaccination, as well as implement other social distancing measures. During COVID-19, however, states use these powers very differently. Some of them, like California and Oregon, issued mandatory stay-at-home orders early on. Others, like Florida and South Dakota, they relied more on advisory approaches. A few states did not issue formal stay-at-home orders at all, and in total, most jurisdictions adopted mandatory orders, but the degree, duration, and enforcement was varied widely. States also diverged greatly on mask mandates, reopening timelines, business closures, and even reporting terminology. In some examples, local governments imposed stricter rules than their states, and in others, they resisted state directives, leading to litigation and intergovernmental tension. Early analyses suggested that stay-at-home orders increased epidemic doubling time, slowing the spread. States with fewer restrictions later experienced severe outbreaks. However, the relationship between policy restrictiveness and mortality is not exactly clear or perfectly linear relationship. Over time, death rates in states with very different strategies sometimes converged, underscoring how complex and context-dependent public health outcomes can be. Decentralized authority produced diverse strategies and variable outcomes within the same national crisis. The Ebola example provides a powerful example of how quarantine authority operates in practice and where its limits lie. Ebola virus disease is a severe and often fatal illness spread through direct contact with bodily fluids. In 2014, as the outbreak spread through West Africa and into major urban centers, the World Health Organization declared a public health emergency of international concern. In response, the U.S. routed flights through designated airports, screened travelers, and the CDC had issued tiered guidance recommending isolation for confirmed cases and risk-based quarantine for those who are exposed. That tiered, individualized approach became central to the case of Casey Hickox, a nurse who had returned from treating Ebola patients in Sierra Leone. Although symptomatic and testing negative, she was initially isolated in New Jersey under a statewide executive order. When she later arrived in Maine, the state sought to impose a full home quarantine. The Maine court ultimately ruled that the state had not shown by clear and convincing evidence that such restrictive measures were necessary. Instead, it upheld active monitoring and coordinated travel, the least restrictive alternative sufficient to protect public health. This case underscores a critical principle. Public health authority is real and powerful, but it must be evidence-based, proportionate, and the least restrictive means necessary. Even during emergencies, constitutional protections and judicial oversight remain firmly in place. The opioid, the opioid crisis has been one of the most devastating public health emergencies in modern U.S. history. Since 1999, overdose deaths have quadrupled, and with more than 841,000 lives lost. And this was as of the time of this book was published a few years ago. Arizona's data were particularly alarming, with hundreds of millions of opioid pills prescribed annually and over 1.6 billion in hospital-related expenses within just a few years. In response, Governor Doug Ducey declared a state of emergency in June 2017. This declaration empowered Arizona's Department of Health and Health Services to enhance surveillance, implement emergency prescribing rules, expand naloxone access, and coordinate statewide response efforts. The legislature followed with the Arizona Epidemic Act of 2018, which limited dosing and prescription duration. The results were measurable. Reported overdoses dropped by 44% in the following year. Prescriptions declined significantly and naloxone distribution increased dramatically. This case illustrates how emergency declarations can accelerate policy reform as well as mobilize funding and create rapid public health impact at both the state and local levels. Lead is a potent neurotoxin with lifelong consequences. Even low levels of exposure, especially in children, can cause irreversible cognitive and behavioral harm. In adults, it increases risk for cardiovascular and kidney disease. Because lead persists in soil and dust, contamination remains hazardous until actively remediated. In Vernon, California, the Exide battery recycling plant polluted surrounding communities for decades. Roughly 100,000 residents, primarily Latino communities, were affected within a 1.75-mile radius. Children living closest to the plant had the highest blood levels, which highlighted clear environmental justice concerns. The response involved community advocacy, technical soil assessments, public health monitoring, as well as interagency coordination and litigation. Notably, however, no state or federal public health emergency was declared. Cleanup has progressed slowly due to funding and administrative challenges, even after Exide closed its doors in 2015. This illustrates how chronic environmental exposures can create long-term public health crises, and how the absence of emergency declarations can shape the speed, scale, and equity of response. Now, at the same time California was grappling with Exide, the Flint water crisis was unfolding across the country over Michigan. Unlike the Exide example, Flint triggered federal, state, and local public health emergency declarations. These declarations rapidly mobilized funding, technical assistance, filters, testing kits, and infrastructure investments. Eventually, lead levels were brought back within EPA thresholds. However, the long-term health consequences remain profound. During the crisis, the number of children with elevated blood levels doubled, and those cognitive and chronic disease impacts are going to persist for decades. Contrast with the Exide cleanup, without an emergency declaration, has moved far more slowly. Cleanup costs related to the Exide cleanup are enormous, averaging $45,000 per yard, with total estimates exceeding 600 million. When the responsible corporation declares bankruptcy, traditional public health orders are often insufficient to ensure timely remediation. These two examples from California and from Michigan highlight a critical lesson that emergency declarations can accelerate coordination and funding. Failing to use them when they're needed may prolong harm and deepen environmental injustice to already vulnerable communities. At the foundation of public health emergency response is the law. The law provides both the tools and the boundaries. It defines what actions are permissible and under what conditions those actions can be taken across a wide range of public health emergencies. Federal and state statutes allocate authority in ways that align with constitutional principles: federalism, separation of powers, and protection of individual rights. These laws are not abstract, they are activated in response to real health risks and emerging threats. Ultimately, decision-making authority rests with public health officials and government leaders. They must apply epidemiologic evidence, scientific guidance, legal standards, and ethical principles to protect the health, safety, and welfare of communities. So while the law creates this framework, it is informed ethical leadership that determines how these tools are used in practice.